Hello, everybody. My name is Teresa Amaral, and welcome back to this Medscape Oncology series on melanoma. So today we'll finalize a discussion on real-world data about adjuvant therapy in patients with BRAF-mutated melanoma. We discussed the visual comparison between immunotherapy and target therapy using real-world data. We discussed the benefit in terms of relapse-free survival and distant metastasis-free survival in this adjuvant setting when we compared the two therapies, showing that a visual comparison seems to show a better benefit for patients receiving target therapy compared to ones that received immunotherapy. We also looked into the differences in terms of quality of life and toxicity profile for both therapies. And now we will look into the last aspect that we need to discuss with our patients, which is what we do when the patients have a relapse. And obviously, it is different whether the patients have a relapse under adjuvant therapy or off adjuvant therapy. Patients that have a recurrence under adjuvant target therapy seem to benefit from PD-1 therapy afterwards in the similar way as the patients that had PD-1 monotherapy as in stage 4 and were treatment naive. Patients that recur under adjuvant PD-1 therapy do not seem to benefit from continuing PD-1 therapy, but they might benefit from other immunotherapies such as ipilimumab or the combination of EP plus PD-1. And the fact that we have data on other real-world data that show, and we discussed this in the episodes before on where to go in terms of immunotherapy in the adjuvant setting, is the fact that even if we have a prolongation in terms of relapse-free survival and distant metastasis-free survival, when we look into overall survival data from real-world, we don't see a benefit when we look into two different cohorts, one before introducing adjuvant therapy and another after introducing adjuvant therapy. So this is also something that we need to discuss with our patients when we propose adjuvant therapy. So the paper that I mentioned before, it's an indirect comparison, and of course it needs to be considered, or it needs to be read as so. There are real-world data that have been analyzed, but obviously we cannot change the data and how it was analyzed. When we look into the relapse-free survival events, we need to consider that these events are dependent on the timing when the imaging evaluation is performed. So if you have an imaging evaluation that is performed a little bit earlier, you might detect the relapse-free survival earlier as compared to imaging evaluation that is performed later. Then, of course, the criteria for including these studies in this analysis was the same, but for including the patients in the different trials, it might be different, which might lead to a bias, of course. Another aspect that it's important to retain from this analysis is that we included both patients with BRAF wild type and BRAF-mutated melanoma because we could not separate these as we didn't have access to raw data. We also included all patients despite the BRAF mutation subtype, so we didn't know if the patients were BRAF V600E or K, although the majority were reported as having BRAF V600E. We also were not able to analyze the data based on the substage 3, so stage 3A to 3D. We included all the patients as stage 3, but not as the substage. Although the median follow-up time it's long, it might be not long enough to capture all the events in the adjuvant setting. So we probably need update of this work in the near future. And we were not able to exclude a couple of patients that were stage 4, no evidence of disease, that were included in the different publications, but we didn't have access to the raw data. Finally, we didn't perform any statistical comparison because of the difference in terms of the publications that we selected, and the comparison was visually performed based on the formula that I mentioned in the first episode of this series. We have some advantages from this analysis. It's the number of patients that were included, more than 3,000 patients, 3,600 patients that were included. We have included patients or analysis that started around 2018, which means that for the majority of the patients, they would have access to PD-1 therapies or PD-1-based therapies as in the modern era when they were progressed, or if they had a progressive disease or a recurrence, better saying. But we don't know if this is the case for all the patients that were included in the analysis. Finally, of course, grouping all the analysis and doing this digitalization using this visual comparison is obviously, I would say, an advantage. And also the fact that we used weighted average calculations to produce these Kaplan-Meier curves, showing that there is a concordance among the different works that we selected for this analysis. So in conclusion, I would say that based on this real-world analysis, target therapy seems to have a better outcome when we look into relapse-free survival and metastasis-free survival in stage 3. Target therapy has a different profile from immunotherapy, and this needs to be discussed with the patient, especially when we look into long-term toxicity. And also the impact in terms of quality of life from these two therapies that seems to be different needs to be taken into consideration when we discuss this with our patients. And with that, I finish this 3-episode series, and I look forward to your comments and to our next series together. Enjoy your day.